not just our physical health. So as we go through today's talk, let's keep that in mind, because we really want to think about a person's 360-degree health. So some of the considerations that we want to keep in mind as well is that health is not just a tumor marker or whether or not a diagnosis is metastatic. It's about quality of life. It's about intimacy, connection with our partner, with our families, with other people, intimacy, sexuality, physical functioning is part of the conversation. So what are sorts of activities of daily living? We call them ADLs for short. So can we toilet? Can we groom ourselves? Can we make food? Are we able to talk with our loved ones? And that dovetails into relationships and social supports. Are we able to find connection? Is that something that's important to us as we think about palliative or hospice care as an option? And then we have to think about psychological impact. Even the words palliative care and hospice can make us sit back. These words can have an impact on our body sensations, our emotions, the level of our anxiety or depression, the level of our happiness. So thinking about how these conversations might increase psychological issues or decrease psychological issues, maybe planning for the future could in fact reduce anxiety for some people and increase anxiety for others. So taking all of these issues into consideration. Next, we want to have thoughts around what are our financial and employment stressors? What things are really impacting us financially or from an employment perspective? Are we self-employed, for example, that impact our ability to make a decision to pursue palliative care or hospice at any point? Spirituality and faith are very important in these conversations. Faith and spirituality provide a sense of connection. For some people, that can provide a sense of loss if perhaps we don't have a faith or spiritual connection or tradition upon which to rely. Some choices are prohibited because of our religion or faith orientation. And we really want to think about our values. Our values include our spirituality, our point of view on life, our worldview. So our values and wishes could be around quality of life or quantity of life. And last, but certainly not least, the impact of these conversations, both the pros and the cons of diagnosis, disease stage, ability and functionality on our caregivers, and what caregivers are available to us. So what is palliative care? I think this question comes up the most for us in clinic. And I work in the Angeles Clinic and Research Institute. We are an affiliate of Cedars-Sinai here in California. And we are an outpatient clinic, and you've probably heard Dr. Hamid already speak today. And when we think of palliative care, we think of that might sometimes be something that you only receive in a hospital setting. But as an outpatient clinic, we also have a supportive care medicine or palliative care doctor who our patients are able to see. So palliative care is a specialized medical care for people with serious illness. The benefit of palliative care at any point in the treatment or medical treatment would be that palliative care physicians and palliative care teams focus on relief from symptoms, could be pain, stress, nausea, energy issues, fatigue, all of these symptoms of a serious illness, whatever the diagnosis might be, whatever the prognosis might be, but anybody suffering from symptoms that could benefit from an additional layer of support. The goal of palliative care is to improve the quality of life for both the patient and the family So this is an important distinction. Sometimes our physicians or treatment in a hospital or clinic might be focused on the patient only. Palliative care addresses the patient, the family, caregivers. So it expands care to provide support to more than just one person, because we do know that any kind of serious diagnosis, ocular melanoma, will impact not only the patient, but also the family and the caregivers. Palliative care is most frequently provided by a team. That team can consist of nurses, chaplains, social workers, dietitians, psychiatrists, and more. So palliative care, you probably have heard palliative care or the term interdisciplinary approach. So it's multiple disciplines working together in order to provide an extra layer of support to the treatment team, so to the primary oncologist. And palliative care is appropriate at any age and at any stage of serious illness. It does not have to be only in the end stage of any particular diagnosis or medical care. It can be provided together with curative care, and it can be provided with comfort care. So really keeping in mind when we're talking about curative care versus comfort care, these are some of the values-based conversations that you might be having already with family, friends, chaplains, treatment team. So who might benefit from palliative care? It's any person who has a life-limiting diagnosis. Supportive care can really benefit patients with symptoms that are difficult to manage. As I mentioned, pain, nausea, constipation, fatigue. Anybody who has existential or spiritual concerns. And that's why oftentimes you'll find a chaplain and a social worker on a palliative care team. I'm certified in hospice and palliative care, because working in oncology, we often do have conversations about end-of-life care. So it can be, again, this multidisciplinary or interdisciplinary approach to treatment, because there is a relationship between physical symptoms like nausea and pain and psychological symptoms such as anxiety. So one can increase the other or vice versa. So if you're in pain, you might have more anxiety. If you have anxiety, you might have more pain. You might have more GI symptoms with anxiety. So really important to address these issues to determine where can an intervention be effective. And it is challenging to coordinate care needs. So that's why it takes more than one discipline, more than one set of training in order to support our patients and caregivers. Palliative care also supports patients and families with complex decision-making. And especially as family dynamics might change, there might be role changes, for example, within a family. And these are conversations that come up regularly with our patients, is that perhaps a wife is now having to drive all the time because a patient is unable to drive. And even something that apparently benign can have deeper impacts psychologically and in a relationship. So again, palliative care is available at any time during the course of an illness. And if symptoms resolve, if palliative care is no longer needed, then you can actually pause the relationship with palliative care and reinitiate it when you need it. And patients who receive support can still pursue disease-directed or curative treatments. Patients who have palliative care support can participate in clinical trials. And one important thing that people sometimes have the impression is that if you are receiving palliative care, that you have to be DNR or do not resuscitate, meaning you can't be full code, which means that full code would be somebody who wants to have CPR, all levels of support, respiration machines in an ICU setting, for example. So with palliative care, you can retain full code support. And it's not something where if you go on palliative care, you also have to select no CPR or do not resuscitate, DNR. So there are benefits of receiving supportive care early on in your treatment. There's been a lot of research being done around the benefits of having palliative care early in your treatment path. So some of the things that are measured in order to support the statement and the research is that they have measures for quality of life. And it's been shown that with palliative care, these measures are actually improved when palliative care is brought into the picture early on in treatment. Also, there's a decrease in caregiver stress, and that is also beneficial to both the patient and the caregivers, because if the caregivers has more stress, then the patient will likely have more stress and vice versa. It's also cost effective from the perspective of having a palliative care team involved. You may not have to seek outside support systems like therapists, for example, when that might be available to you within the palliative care team. You also might have a decreased length of stay in an acute care environment, so decreased length of hospital stays, which means you get to spend more time at home or at work, wherever it is that you need to be or would prefer to be, rather than inpatient in a hospital. And lastly, and I think really importantly, is to understand that palliative care can actually improve overall survival. And if at any point during the conversation, please use the chat window to type in any questions. We will have a question and answer period towards the end of the talk. So I think the most important thing, or one of the important things in treatment, is to understand the difference between a primary care or supportive care encounter versus a specialty palliative care encounter. So a primary supportive care encounter can be from your regular medical team, your oncologists, your nurses, your intensivists and surgeons, social workers and chaplains, who you meet in a hospital stay, in a clinic. These people may or may not have specialty training in palliative and hospice care. It can be provided by all providers who take care of patients who have a serious illness. And that's contrasted with specialty supportive care. As I alluded to, anybody who's working with you who is specialized in supportive care, and specifically doctors, have special fellowship training. Social workers have special designations and additional training in addition to their regular degrees. Chaplains, again, will have additional training in hospice and palliative care. And this is important because this specialty focuses on symptom management, focuses on communication skills, and end-of-life care. So supportive care medicine teams are comprised of wellness, resilience, and survivorship programs. Some clinics who are part of larger institutions have additional resources. There are also additional resources in the community. So for example, the cancer support communities, they're a national organization that has additional wellness activities. In some states, they're still reduced to having only online offerings because of state restrictions related to COVID. In other states or parts of the country, there are these programs that are already back open post-COVID. These can include things like mindfulness classes. It can include things like arts and crafts, being in a room, support groups with people who are also working with serious illness. Other things that are important are connecting with other people going through similar diagnoses. So physical medicine and rehabilitation can also be a part of the conversation. We have our wellness team is going to be working on having an art support group for patients remotely using Zoom. So there's a lot of options in various communities. And because many of these offerings are now online due to COVID, you can participate in some of these offering support groups and wellness activities that may not be available physically in your community. But now that they've moved online, you can participate from anywhere across the globe. So symptom management. So the first thing many people think of when they think of palliative care is pain. Nausea is a close second. Anxiety is something to consider as a very important aspect. Depression as well. Depression can set in. And I'll talk about grief in a little bit, but we may not know that irritability and anger are signs of depression. So that's something to pay attention to as well. Fatigue, certainly, and energy conservation are topics that a palliative care team can assist with addressing. That can be either with pharmaceutical intervention or with behavioral interventions. And you see, on the screen, the images that we have here are pharmaceuticals and their stem. So there's pharmaceutical and non-pharmaceutical interventions that can be beneficial. Therapy can be a great source of support. Sleep management can also be addressed by pharmaceutical and non-pharmaceutical interventions. There's an entire topic called sleep hygiene that can be worked with that doesn't necessitate having medication. A lot of the patients that I see want to take fewer medications, whereas other patients are fine with whatever medication as long as it addresses the symptom. And that's a very personal conversation. So it is important to get to know your medical team as well as your palliative care team, so that you can really start to discover the nuances of what your preferences are. Do you prefer pharmaceutical or non-pharmaceutical interventions? Are those interventions dependent on the degree? So if you have pain you might have, for example, if you have an 8 out of 10 pain, would you prefer to take pain medication? But if you had a 2 or 3 out of 10 pain, would you like to do something that's non-pharmaceutical? So it's having those options available. It's about receiving education and support from the teams in your hospitals and communities. Nutrition is also something that's important to consider around symptoms. If nausea, GI issues are present. And again, back to mood, anxiety and depression, irritability, anger, sadness, and even having crises of faith. Now, that's one of the things that we don't talk about a lot, but it is something that does often happen. We don't know why, quote unquote, bad things happen to quote unquote good people. So crisis of faith or being angry with a spiritual tradition or entity that has guided you thus far can happen. And that can be really, really disturbing to many people when they start to lose faith. And there can be many, many other side effects where there might be pharmaceutical and non-pharmaceutical options. And as I mentioned, research is being done. This was a study, and it's one of the seminal studies that was presented in 2010 around improving quality of life for patients and caregivers. This was a study done with a group of non-small cell lung cancer patients, and it was a randomized study. And the outcome was that there was a change in health-related quality of life and mood from patient and caregivers' baseline to 12 weeks of being on the study. So quality of life improved, depression decreased or was reduced, and anxiety was reduced. And also, I think importantly, is that the study showed that having palliative care involved early on did not hasten death, or it did not change quality of life, but in fact, it at least maintains the same length of life. And I think that's important to think about, because some people might argue that if you receive palliative care early on, it's a change in mood set, but rather it's a choice to improve quality of life and health status, mental health status, physical health status at every step along the way in treatment. So this brings us to really talk about the differences between palliative care and hospice care. And for people who have never been through a conversation around serious illness or never been part of a journey of somebody who's been diagnosed with cancer or melanoma, it's really important to understand the distinctions because they're pretty clear once you're aware of them. So palliative care, as we've been talking about, that is a medical specialty. It's available to any patient with a serious illness at any point in the patient's journey. A patient can still receive aggressive care, participate in clinical trials, can really be aggressive in their medical care, and they can have people on the palliative care team to support them with psychological, mental health, with physical health, with symptom management. Now, hospice care is very different in some ways. So hospice care is a managed care for patients with a terminal illness. In order to be able to participate or choose to have hospice care, a patient must have a prognosis that is less than 6 months. So that's really important to keep in mind. Hospice care is specifically for patients whose prognosis is less than 6 months. And hospice care has the focus of comfort care only. So at the point where hospice is the choice that is correct for a patient and family, it is important for the patient and family to understand that in hospice care, there is no disease-directed treatment. And this comes back to the conversation about comfort-focused care only. So what that means is that care is focused on providing comfort for the patient. So there wouldn't be any infusions, most likely. There wouldn't be any trips back to clinic. In the hospice care model, typically the hospice takes over all aspects of medical care for the patient. They have a team as well that's able to do that. So what to expect with hospice care? You can have counseling and support. There are chaplains, there are social workers who are part of the hospice care team. The hospice care physician becomes the primary physician for you at the point which you decide to sign a contract or an agreement with a hospice care agency. A hospice would help in coping with illness for the patient and family. They would provide additional guidance with end-of-life issues. They provide basic medical care, again, with a focus on controlling pain and symptoms. Also, hospice care usually takes place in home. And when the hospice agency comes in, they are not a 24/7 presence in the home. They come in a certain amount of times a week. That's a discussion with any hospice provider about how many times a week, what's the frequency, what's the duration of the visit, who is coming for the visits. And having a hospice agency or hospice visit on a regular basis does give respite to the caregivers and families. You do have access to a member of the hospice team at all times. And oftentimes, as I was saying, family members, caregivers, they do become the primary source of support for patient, and you call in the hospice resource whenever needed. One thing that's really lovely about hospice is that they also take care of any medical equipment. So if you come to a point where you might need a medical bed in the home or a commode or something along those lines, then the hospice agency will set that up. And typically, what's important to know is that if a decision for hospice is made, then usually a hospice can be in the home. They can have equipment in the home by the evening. They'll come to your home, meet with you, answer questions, determine your needs, assess the home, see what might work well for the patient and caregivers. And that can all be set up in, by the end of a day or at a minimum, maximum 24 hours. Now, hospice is usually covered with most insurance programs, including Medicare, Medicaid, most private insurance programs, HMOs, and other managed care programs. Hospice will cover all expenses typically, and insurance coverage for hospice can vary on private insurance plans. So it's important to know what your insurance coverage is and what is covered by hospice and what is not. So if you're interviewing a hospice agency, please do make sure that you have that conversation. What is covered by the hospice contract and what is not covered by the hospice contract based on the insurance of the patient. So it's really important to understand this. If a family is a lower income family, there may be financial support programs through the hospice, and it's really important to have those conversations. And some physicians prefer to have those conversations early on, some later on, and it really comes down to advanced care planning and what decisions and values have been identified by the patient and family. So this brings us to the topic of advanced care planning. Advanced care planning is something that's critical in the process of any serious illness. And in fact, I believe anybody who chooses to drive on a highway, especially here in Los Angeles where I'm based, it's important to have advanced care planning documents regardless of serious illness diagnosis or not. So there are 3 typical documents which you might be thinking of. There's an advanced directive for healthcare, and often shorthand, we just call it an advanced directive in the healthcare system. You may have seen one of those already. Some patients have done estate planning and they would have a living will. And then the last thing is a power of attorney. And this is a legal document for financial matters. So I think this distinction is really important for us to go over. An advanced directive for healthcare could be called a power of attorney for medical issues. What it does is it determines who can help you make medical decisions if you were in a position where you were no longer able to articulate or make decisions for yourself. A power of attorney executed by an attorney, by a lawyer, can include power of attorney for financial matters. And that really falls under the auspices of estate planning. And some estate plans and living wills do include sections that include healthcare wishes or advanced directive for healthcare. So in some states, we have both an advanced directive for healthcare and a POLST. Now, a POLST is a physician's order for life-sustaining treatment, and this is an actual doctor's order that is signed by a medical professional, MD, DO, a PA, or an NP. So advanced licensed medical care. And the advanced directive will outline 2 things. A, who are your medical decision makers, a primary and alternate or secondary alternate? At what point can these decision makers make decisions for you? Oftentimes it's only when you are no longer able to make your own decisions. Sometimes, depending on the age and the level of cognitive ability of a patient, agency to make decisions earlier. And then secondly is the important part where we identify the values and wishes, treatment wishes. Does somebody want life support? Do they not want life support? Do they want to allow a natural death, or do they want CPR? What feeding tube options do people want? Artificial nutrition. So let me tell you a little bit about how advanced directives in a POLST form, and I think POLSTs are called different things in different states. I think in New York, it's a different acronym, but again, this would be a physician's order or medical order for life-sustaining treatment. So ideally, all adults would have an advanced directive completed when they turn 18. To identify who medical decision makers would be and what values are. Now, these advanced directives ideally would be updated every 5 years at a minimum, or in the event of a serious illness or diagnosis. If a person is diagnosed with a serious illness or advanced illness or any issue of frailty or cognitive decline, early stages, then you would want to create a POLST form. Now, this form in our state in California is bright pink. It's something that we recommend to put on a refrigerator so that if 911 and paramedics were called to the home, then they would be able to see that, to see whether or not that has been completed. And then when an advance directive is completed, when a POLST is completed, these two documents work together. You can think of a POLST as an executive summary of your advance directive. And lastly, with these documents, the patient's treatment wishes are honored. And for many people, retaining this level of agency and control is incredibly important. So advanced directives specifically, and I put a humorous cartoon on, is that if you've never had the conversation with your loved ones about what your wishes are around medical treatment, around who your medical decision makers are, that puts the treatment team in a difficult position, because if you're not able to articulate your own decisions when you're able to language them, and it comes to a point where you're no longer able to speak to your wishes, then your family would be in the dark about what your wishes are and who your decision makers are. So it's really important to facilitate these conversations. And in our culture, these are not conversations that we have, even if somebody in the family has a diagnosis with a serious illness. So the impetus for really being on top of advanced directives for healthcare is to establish these conversations so that the medical team doesn't go beyond the wishes in their care and treatment of the patient just because the patient never had the conversation. Also, in some families, family dynamics can be tricky. In some states, next of kin would be the automatic medical decision maker, but if there's an estrangement between next of kin, or if the next of kin, say a husband is unable to make a decision because he doesn't cope well with difficult decisions, or somebody's in a partnership that's not legalized, but the partner may know better than a brother, sister, mother, father what the patient would want, but that hasn't been written down, that could create a lot of friction and drama in a situation where there's not a lot of time to make medical decisions. So having an advance directive is protective for the patient, for their caregivers and decision makers, and also it helps the medical team understand the wishes of a patient. So this is an example of a POLST, or the physician's order sustaining treatment. There are really four sections that are important. Do you want CPR? And again, that's back to the conversation about being full code or DNR. So DNR is allowing a natural death, no CPR. CPR can be very violent. It can break the ribs of somebody. And it's not like, the TV show ER, where many people have a successful outcome, especially in the case of serious illness. Or does somebody want CPR? The second area is what level of medical intervention. And there's full treatment, selective treatment, and comfort-focused treatment. And these are really in line with, if you do select DNR, then you most likely would say you might have a trial period of full treatment, but you might just want selective treatment, or you might want comfort-focused treatment. If you do want to attempt CPR, then you do want full treatment. The next session talks about nutrition wishes. Do you want a trial period of artificial nutrition, a long-term artificial nutrition, or no artificial nutrition? The next section says, is there an advance directive in place? If so, has the doctor signing this document reviewed the advance directive? And there's a space to write in who the healthcare agent is. The page, which is the second image, you can actually write in an additional contact, so a secondary decision maker, or if there's not an advance directive, that's where you would put the decision maker. And then there's signature for the patient and for the physician. This is a document called the 5 Wishes. Now, this might be a little bit different from your state's advanced directive rules. The 5 Wishes document is a document that we use with patients who might be coming to California, for example, for treatment, but their residences in Nevada, Arizona, Hawaii. They're coming to us for a specific treatment. Now, we do a lot of phase 1 clinical trials, so we do see a lot of out-of-state patients. So you do want to make sure that whatever advanced directive you execute is valid in your state of residence or the state where you're receiving treatment. The 5 Wishes, it accomplishes the same tasks as an advanced directive. It identifies the decision makers if the patient's not able to make his or her own medical decisions. It talks about your desired and undesired medical treatments. Are there treatments you do not want and ones that you will accept? So, for example, if you're a Jehovah's Witness, if you do not want blood, if that's a wish, that would be someplace you would capture that, or directive. Also, the 5 Wishes asks about what are your comfort choices, how do you want to be treated by the medical professionals as well as your family, and what is important for your loved ones to know around end of life and treatment wishes. And here are some additional considerations in advanced care planning. So for those of you with children, grandchildren, dependents, you want to think about guardianship. This can also include pets and funding for pets. Funeral planning can also be captured in 5 Wishes and some advanced directive documents, and estate planning. Power of attorney for finances, that's a different document for an advanced directive from healthcare, or the 5 Wishes document. In some advanced directives, organ donation is discussed. And lastly, and this is only applicable for some states, in some states, including California, it's actually now legal to enact, we call it in California, the End of Life Option Act. I believe it's also valid in Oregon and some other states. I don't have an exhaustive list. But if you were to be at end of life and you have a life-limiting diagnosis in California, after going through several hurdles and steps, you can choose to administer an end of life medication, and it has to be self-administered. Now, some hospice agencies will allow you to administer the medication while they're still the guiding physicians. So if that's something that's important to you as a patient or to your loved one, it's important to explore this conversation with your physician team sooner rather than later, so that you understand what activities or what milestones have to be accomplished in order to receive this prescription. This prescription is usually out of pocket and not covered by health insurance companies. And if there's questions on this, I would direct you to any state-specific laws. And again, if there's questions on this, please let me know. So that brings us to the crux of this talk, is when to decide. When do we decide to have palliative care as part of the conversation? And when do we decide that it's time for hospice? So when do we call in palliative care? Palliative care can be called in at any time during the treatment cycle for specialized symptom management. And again, the symptoms can be physical, so biological, psychological. It could be social. Perhaps there's not a caregiver or decision maker available. So what do we do? Who do we decide if we don't have somebody we would want to be our medical decision maker? And of course, spiritual. And hospice. Hospice is a wonderful option when the prognosis is less than 6 months and the hospice choice is aligned with the patient's values and wishes. What's important to think about is that hospice is oftentimes important to understand as an option, that is performed in the home. Although there are hospice houses or some hospice agencies working inside an acute care setting, hospice is oftentimes something that does take place in the home. So at this point, I'm going to go ahead and turn over to a question and answer period. If you have additional questions, please go ahead and put them in the box, and I'm going to move into question and answer. Thank you.
Great. Well, thank you so much, Jennifer. Like she said, if you have any questions, please drop them in the chat. Look at a few people have asked. What advanced care steps have you taken? Jennifer?
I'm sorry, can you repeat the question?
Oh, no problem. So someone has asked, what advanced care steps have you taken?
What advanced care steps have I personally taken?
Yes, or that you recommend taking? Or
okay, sure. So I think the first step in advanced care planning is absolutely to have an advanced directive created. I think having an advanced directive is incredibly important. It allows you to have these conversations with your caregivers, with your loved ones, and it allows you to start to contemplate what you want. End of life is not a conversation that we generally have. One of the things that palliative care can facilitate is a goals of care conversation. We in palliative care capacity can provide an advanced care planning document. So we often have those on hand in the hospital and in the outpatient clinics. So we can give you a form, we can provide education, we can assist you in understanding the nuances of how to articulate what treatment you want, same with a POLST. So we have those in our offices as well. So I would recommend starting with advanced healthcare document.
Great, thank you. And then someone wants to know, do you have any tips for going over your treatment wishes with caregivers?
Absolutely. So I think the first thing that you'd want to do is take time to understand the advanced healthcare planning document. So if you use a advanced directive, for example, or a POLST or the 5 wishes or even estate planning, to start that conversation. So the first step is beginning the conversation. And if you don't feel comfortable starting that conversation, if you have a conversation with imminent death, then you can actually have a medical professional, so palliative care physician, social worker, chaplain, support you in having that conversation. Maybe when you're at a clinic visit or at a telehealth visit, we can actually help you facilitate those conversations if there's not any comfort in doing so on your own. So if there's too much fear or anxiety around initiating that conversation or what that conversation would mean, please use your professionals to do that. You can also use a chaplain. You could also use the pastor of your church or somebody within a religious institution, a rabbi, whatever it may be, to help guide those conversations so that if, observing religious rules, regulations, and rituals are important, they can help facilitate that inside a religious institution as well.
Great. Another question. What self-care activities would you recommend taking up as a patient or a survivor?
So I think really going through the process of having ocular melanoma diagnosis, whether or not you've had multiple lines of treatment, if you're on a clinical trial, I think that self-care is incredibly important. And I know, earlier today, there was a conversation with Ziva Osborne, and she was talking about social connection and self-care as well. So having some type of practice in place where even and especially in the midst of COVID, you are connecting with people, You might not be able to connect in person because you might be immunocompromised due to your diagnosis, but doing FaceTime versus just being on a phone, seeing somebody else's face is much more powerful than just hearing their voice. And making sure that you engage, as I mentioned, support groups that are now virtual are options. Whereas you might not have had access to these support groups previously because you didn't have any in your community, you can participate in any support group in any part of the country or the world, basically, because of technology and the changes in technology due to COVID. So connecting with others, having a regular practice, either faith-based or spiritually based, connecting with your body sensations, and understanding that grief with a diagnosis is very often present. The minute that anybody receives a cancer diagnosis, you might trigger a grief process. This is called disenfranchised or anticipatory grief. And grief has many stages. Some of the recognized ones are depression, anger, bargaining with God or spiritual beings, denial, and acceptance. And these are not linear stages. So once you're done with anger, you go to sadness. Once you're done with sadness, you go to bargaining. Once you're done with bargaining, you're fully accepting your diagnosis and your medical status. So understanding that mood can change and seeking support around that.
Thank you for that. Okay, so we have time for one last question. If my loved one is in hospice at home and is undergoing pain management, how does that work if they cannot take oral medication? If a hospice nurse available, or is a hospice nurse available for urgent assistance with an injection?
Typically, hospice nurses are available, but there are medications that if somebody can't swallow a pill, there are medications that can be given under the tongue that can be dissolvable. There are liquid medications, so it doesn't always have to be an IV or an injection for pain medication. The pain medication, there's multiple ways to be administered. So for example, if somebody has terrible nausea, there are medications that just dissolve on or under the tongue that can be administered. And that's the same with antidepressants. That's the same with some pain medications. They come in liquid and patch forms. So a patch of medication can be on. So usually there is a person on call for hospice 24/7. And each hospice is different in every part of the country. So that's something to ask the hospice when you contract them about, what do I do in emergency situations? What if my loved one can't swallow? Now, if your loved one has a feeding tube, some medications are administered through the feeding tube that you can actually administer.
Thank you.
Absolutely.
Okay, so that's all we have time for today. I just want to thank you so much for all the information you've provided. I know our attendees took a lot away from it, so thank you again. I'll give you a virtual round of applause.
Thank you.
And I will be taking both of us off present mode as we go into our 10-minute break. So,
all right. Thanks everybody for attending. I appreciate having you here.
Thank you.
Okay. Bye-bye.